The following is a conversation. It has the features of any conversation, such as imperfectly expressed thoughts, ill-considered opinions, and the notions of several sleep-deprived brains. Try not to get your stethoscope in a twist about it.
I like to joke that I'm the least professional member of the Office of Student Affairs and Curriculum. Everybody else is very,
And that's including when the students walk in and out, so...
Yeah. Everybody else is very professional. They don't swear. They don't, make weird... I try not to make off-color jokes, but weird jokes that nobody else gets.
Oh, I think we might be on the same page.
Nice.
We'll have to talk about.
Not as weird as you, Connor.
They've done studies on cussing. Actually, that's a topic for another time. But
that people who swear
have a larger lexicon.
Are yes.
Yep.
I was going to go with
interesting.
I was going to go with much.
I definitely increased my curse word volume when I became an intern.
That makes sense, yeah.
The year of literacy, intern year.
Yes, for sure. It was like, oh, you were in medical school? Great. Now we're going to start brand new. So that was the advice I had gotten from my attendings on one of my first days. Like, you're just starting from scratch again.
Everything you thought you knew is...
Yep. Yeah. Now it's the real world.
Meandering in the margins of medicine, it's the Shortcoat Podcast.
Weird news,
fresh views,
helpful clues, and interviews.
By students, for students.
Subscribe to our weekly show at theshortcoat.com.
Welcome back to the Shortcoat Podcast. This is a show that gives you an inside look at medical school from the students drinking from that fire hose. It's a production of the University of Iowa Carver College of Medicine. I'm Dave Etler. With me today in the SCP studio, it's new co-host PA1 Conner Liser.
Close enough, Lisa.
No, don't do that.
You could say Samantha. It doesn't matter to me.
I should have checked. I assumed it was Liser. It's Liser.
Yeah. I think it's German.
Yeah. I think you need to change the spelling of your name. I think
so too. I'm actually looking to get married so I can take her last name.
What's her last name?
I don't know. I'm gonna find it though.
Oh, you soon. Okay?
I guess I'm kind of putting the cart before the horse there. But hi, I'm Connor. Thanks for having me on the podcast.
Well, joining us from our satellite studio in Des Moines, it's M2 Jeff Goddard.
Happy to be here.
And if you thought that was all shortcoats, shame on you. Shame, because we've also got a special guest. Silvia Caswell is a physician at Loma University Health, and she's here to talk about her sleeper specialty, preventive medicine. Welcome to the show, Dr. Caswell.
Thank you so much for having me. It's a pleasure to be with you all this morning or afternoon, wherever you watch that.
Whoever listens, they don't know.
No, you kind of lose track at one point.
Preventive medicine is on our list of sleeper specialties. Programs that people might not know or think about, but should. Jeff, you've said on the show before that this is going to be your career. What do you?
Yes.
So what do you think makes it a sleeper specialty?
So I remember I talked to one of our deans here about what we might do about getting an accredited program here in Iowa. And she's like, is that an accredited residency? Is that a specialty, a real thing? So the fact that the dean didn't even know, I was like, okay, all right. So I think in large part it's due to how it's funded and therefore its relationship with match day, because it doesn't participate in the big match day, right, in March every year. I think a lot of people just kind of discount it or don't recognize that it even exists. And another part is that its name, preventive medicine, sounds like the thing that everybody else already kind of does. So they're like, oh, that's just an aspect of, say, family med or an aspect of peds or whatever.
Sure, yeah.
So I think that's kind of why. But I don't know, Dr. Caswell, what do you think about that?
Yeah, for sure. It's usually an incidental finding for a lot of folks in medicine. And they're like, what? Preventive medicine? That's a thing. And usually I think of it as the bottom foundation of first line of every, disease that you should be doing that everybody overlooks because we just jump into pharmacotherapy, right? And so we avoid talking about the foundation. And I think that's where preventive medicine lies. And it is one of the 24 American Board of Medical Specialties recognized in the United States. And however, it is largely unknown. It is an incidental finding a lot of the time. And so people don't generally know it exists. So,
and it's got some of the funner, I don't want to say subspecialties, but like under its umbrella have some of the more fun things that we think about in medicine. So I think lifestyle medicine, for example, which is what Dr. Caswell practices, aerospace medicine, which is what my wife is really interested in because she wants to go to space or work with astronauts. All of those kinds of things fall under preventive medicine. So I don't know. It's more fun than people realize. They just don't know that it exists. So.
And it's not a subspecialty, right? It is a full,
no, it's its own
top of the umbrella.
Specialty. Yeah.
It is. So, yeah. So basically, preventive medicine, we are trained in health promotion and prevention of disease, death, and disability at multiple levels. So not just, your clinical one-on-one with patients, but also at the community level and, like even more broad levels. So because of that training, there's different types of ways that you can practice preventive medicine, but the three main areas underneath the preventive medicine umbrella are occupational medicine. So those are your, physicians that are dealing with employment physicals and, like anything related to work. Fit for duty, the military loves OCMED. And then there's general preventive medicine and public health, which is what I do and what my training was at Loma Linda. And then the third one is aerospace medicine. Now, that is typically thought of military, because you're dealing with the pilots that are flying the airplanes and all those physiological changes that come with the changes in altitude and so forth. But there is a combined program in Texas, I believe, that does civilians, and it's a combined internal medicine with aerospace medicine that people can apply. But I know very little from aerospace medicine, although some of those concepts do fall under our general preventive medicine boards. So we do have to learn some of those. And then there's like hyperbaric medicine underneath that, addiction medicine as like the subspecialties of prev-med. So there's a few more.
So I imagine that aerospace medicine is going to become more and more important as a civilian occupation with the rise of private companies doing basically space travel and other related things. So
I was just reading on that actually, and it's burgeoning right now. And they talk about just the number of studies, and don't let me speak out of my depth knowledge.
We don't
in any sense.
Look, this is your first show.
Yeah. Okay.
So I need to tell you that.
No worries.
How many strikes do I get? That's
no.
what
I need to tell you that we opine.
Okay.
On the show,
as we should, and I know Jeff and I have had one too many lunch conversations. Usually at this time, we're usually just bantering.
Yeah.
But in the discussion of that, they talk about the research that we have to date, and there's all these major pushes right now from private corporations to look at, okay, well, is it even possible for us to have somebody on the International Space Station? I think they say the record is like 569 days or something in that ballpark. And they say, well, okay, what happens to the body at 700 days, at 800 days? What happens with this low gravity? And I think there's new research that's starting to get funded now just because of the rate at which we're looking to move back, listen to that. But
I mean, there's a new push to get to the moon again and establish a base on the moon that will be sort of like the International Space Station, but on the moon, and then eventually go to Mars. So anyway, I know that's not...
There are aerospace fellowships that are more focused towards emergency medicine, which is fine when you're thinking about, well, if somebody's going to go live on Mars, right? But I think for the most part, a lot of what aerospace medicine from the preventive medicine side is focusing on is like, if you have an emergency on the ISS, like a health emergency, for the most part, most of the time, it's probably because somebody messed up before they got there. That was something that probably should have been prevented. We should have been looking at their cardiological health or whatever,
Yeah, you don't send somebody up there right now if they're not completely healthy as best you can determine.
Yeah, and I think those employed by NASA themselves, they talk about so much of their job is looking at, okay, from a pharmacological standpoint, what can I send up? Every ounce has to be accounted for, and gets a little bit into the weeds there from, like you said, the pharmacological aspect, but interesting nonetheless.
We're going way too long on aerospace because
let's get.
But it's interesting, right?
It is. It's totally.
I mean, you can work for the FAA doing your employment physicals for your pilots that are just flying for regular, airlines. My brother is an airline pilot, and so he deals with that a lot. So yeah, there's definitely room there for employment if needed, and people are interested in and want to get that type of training. But generally speaking, it's more military.
Yeah.
Because you've got your pilots and so forth, and they need to make sure that they're fit for duty.
Yeah.
So what does your practice look like? Like what your career path or your current practice? in prevention?
Sure. Yeah. So I can probably start with my background into like how I got to where I am, because I did really use my residency time to make sure I was fine-tuning my potential employment after, because preventive medicine, so I'm speaking from general preventive medicine, public health. OCMED is very straightforward, aerospace very straightforward. General preventive medicine, public health is very what I call broad spectrum, in the sense that you can get these jobs in various different types of agencies and healthcare organizations. So you can go do academia, you can do public health and government, you can go do military, you can do clinical preventive medicine, private and whatnot. So I was able to fine-tune that through residency. However, I'd first come across lifestyle medicine. That was my entryway. I had a personal history of, like, at the very beginning, after the birth of my third kid, I lost about 85 pounds through lifestyle behavior changes alone. And when I was in medical school as a first year, I came across American College of Lifestyle Medicine during an MSK lecture. And I was like, what is that? And I was a health coach at the time, and I was teaching group fitness at the gym at medical school. And then fast forward, I started a lifestyle medicine interest group, and it was through that I found preventive medicine. I started working with some of the folks here at Loma Linda, because lifestyle medicine originates from here, as we are one of the 5 blue zones of the world.
These are areas where people tend to have long, healthy lives.
Correct. Yes. And very much so. So here at Loma Linda, it is exactly what they say it is. Like, there, lots of restaurants with plant-based options and vegetarian options because of the Seventh-day Adventist population here, because Loma Linda is a Seventh-day institution. So, and then a lot of walking and biking pathways, and people are very social around here. So you've got all these components that make people live a really long time. So I wanted to come here to do lifestyle medicine. They have preventive medicine here. But like you were saying earlier, preventive medicine is considered part of any other specialty. You got family medicine, internal medicine, peds. So you're going to be able to use a lot of preventive medicine. And that's what I thought. And so I'd chosen family medicine coming out of medical school, and ended up going to one of the pilot sites for the lifestyle medicine residency curriculum, which is now available in dozens of residencies throughout the United States. And so I went to Southwest Florida at an amazing family medicine program with Lee Health and FSU in Fort Myers. And it was about 3/4 of the way through my PGY1 that I realized family medicine was not for me. It felt very reactive. And I thought, how on earth am I supposed to address 17 different conditions, which are most of them chronic, and be only given 15 minutes to do all of that? And that just didn't match what I was wanting. But I've always wanted prev-med. The intent was to do prev-med after I finished family med. And so my program director at the time was very supportive. And so I was able to fast track my prev-med journey. So prev-med, you have to have at least 1 year, at least a PGY1, before you can start it, or a transitional year somewhere, or you can finish an entirely different specialty if you want and then come into prev-med.
So just for the jargonless, what PGY1 means is...
postgraduate year 1.
Right. So this is your intern year in whatever specialty.
Exactly. So whatever it is that you choose to do, even if you stop early after PGY1, you just have to have at least 1 year after medical school to come into prev-med. So I ended up with a gap year because I made my decision way too late. In Florida, you can practice independently after a year of training, and you've gotten your license after taking either year level 3 or step 3. So I worked independently and waited to get my spot at Loma Linda, which was always the dream, and it's what I got. And so I was able to come here and tailor my training. So I knew that I loved lifestyle medicine, but also had left family medicine because I wanted to make a bigger impact. And I knew I wanted public health and some sort of population medicine. Now, OCMED and general prev-med and public health require that you get an MPH prior to finishing your training. So here at Loma Linda, they put you through an MPH. It's free. So part of your training, you're also in school. So different programs throughout the country, they'll either put you through an MPH in 1 year, then you do prev-med, like all your clinical rotations and everything, or you just do it concurrently through your 2 years in Loma Linda. That's what they did.
How was that?
I was in an MPH at the same time. You know, it felt much better controlled than being an intern.
Okay.
Because I
feel like that's a low bar.
Even
it's better than an intern here. Okay.
Yeah. And I feel like I was talking to somebody about this the other day. You just know, you learned how to study, right? Because you did medical school, and medical school is so tough. And, you know, a lot of people have to retrain themselves on how to study. But when you go through that rigorous, you know, academic 4-year journey, you kind of figure out how to study. So when you go and do your MPH, it feels more manageable because you know how to handle it. Mm-hmm. It's still quite a significant volume, but here, you know, my experience here with our program, they do a pretty good job at making sure that you have time. So we basically worked 4 days a week, like Monday through Thursday, and then Fridays were our didactic days, and then days that we were given time to actually study. But I also had 3 kids, right? And so like my time is pretty tight.
Jeez.
So I had to study on the weekends as well. But it felt very manageable and much better controlled than it did during intern year.
So is prev-med a 3, not to interrupt you, is prev-med a 3-year residency or 2 years on top of your intern year? Which 3 years?
Great question. Depending on how you come into it. So if you apply as a PGY1, you know, during your intern year, then you need 2 years. If you finish an entirely different specialty, there's 2 ways to do it. You can either apply for like a regular 2-year program where you're going to get your MPH. Mm-hmm. Now, this is for most programs. Loma Linda has what we call a +1 program. And what that means is that residents from any specialty can be, I mean, we have PM&R starting here with the next academic year. They already know they want to do prev-med. And so what they do is that they complete at least half of their MPH prior to starting 1 year of prev-med, which would be a fellowship at that point. And then they finish their MPH and their fellowship in prev-med at the same time.
Okay.
So we have 2 fellows who I'm overseeing at my full-time job through public health right now, and they're family medicine trained. They already had half of an MPH coming in, or a complete MPH, and then they're finishing that at the same time they finish prev-med. Loma Linda also takes some folks through a transitional year spot, and so they can apply as medical students, but that is specific to our program here, and it can be quite competitive because of interests and because a lot of people come here because of the lifestyle medicine component.
So what does your day look like?
Sure. Yeah. So I
got there, Dave.
We got it.
You know what? Again, the magic of the edit button.
So my day-to-day now, so I was able to tailor my residency program training to what I do now. So I have different hats with the knowledge of I like clinical work, and I also like non-clinical and administrative work. So I was actually chief resident in my program, and through the networkings of being involved with American College of Preventive Medicine, which I'd like to talk about in a little bit, I was able to land some really cool jobs. So my full-time job, my Monday through Friday job, is at the County Department of Public Health for San Bernardino County. It is the largest contiguous county in the United States. It is so large we have to divide ourselves into regions, and every region is a little bit different in terms of what our population looks like. And so when we're trying to target initiatives and, you know, things that we're trying to work on in public health, like we have to be very strategic depending on the region because it can be so different. And we have a very large underserved area, despite the fact that Loma Linda is a blue zone of the world. But if you drive 5 minutes north on the other side of the freeway, it's one of the poorest, most underserved areas in Southern California. So we have plenty of opportunity to work with the underserved, you know, in terms of public health. And so my 2 hats in public health are for chronic disease prevention. So I'm currently dealing with our community health assessment and the implementation side of it to try to target our activities that will meet our strategies for the next 5 years for the county. And then also I have some aspects of maternal and child and adolescent health. So those are my 2 hats. And I also oversee our general preventive medicine residents. And so I do a fair amount of teaching them as they come through county, and they also get experience to rotate in TB clinic and HIV clinic and STI clinic as well to manage those populations. And then, and those are with other attendings. My part-time hat are with telemedicine, and particularly with lifestyle medicine and obesity medicine. And so I work for Weight Watchers Clinic, and I really love doing that. I like the one-on-one interactions with patients. And because I had my own personal weight loss history of about 100 pounds now and sustained over time, I feel like I can empathize a lot with patients and understand what they're going through because it is so difficult to lose weight. So I'm able to do that part-time, and it's pretty flexible, which is great. And then I'm just back now onboarding with Loma University Health with their preventive medicine department. And continue to work with the residents and deal with grants as well for our department. So just have different hats for the things that I like to do.
That's a big hat
That's a pretty
rack.
full hat rack. Yeah.
Let's not do this. Let's not do
Shortcoats, if this episode is worth listening to this far, it's worth sharing. So blast us on your socials. And if you want a sticker for your trouble, send us a screenshot. Thanks.
In terms of your public health hats and the roles you play with that, what does funding look like that nowadays? Is there actually good funding? And I don't know if you're allowed to say this or not, but what does that look like?
No, there is. They have different funding streams for maternal, child and adolescent health, MCH. So there's funding for programs like that come funneled directly from HRSA, or maybe they come funneled through our state health department. So there is funding for programs. So for example, like I'm dealing with the fetal infant mortality review. And so we've been able to expand our program to include maternal interviews to be able to understand and obtain qualitative data on, what is their experience with, their fetal or infant loss, and what were the barriers that they were seeing that, so we can prevent those from happening again. The interviews are so helpful because they help us see a clearer picture, because they can say, well, this mom had late prenatal care entry, but it doesn't say why, and it's not until the interview that we have a full understanding of the difficulties they had with, getting insurance coverage or, is that healthcare access and whatnot. And those are things that we already know that are going on just in general terms.
What you just mentioned is something I've heard other people say, which is that, when you see a patient, you barely know their story, so for instance, that they didn't get prenatal health care. And so you might assume there are reasons, you might assume some reasons for that. But it's important to sort of interrogate that initial perception so that you understand really what the problems were for that person.
Exactly. So now that I've gotten preventive medicine public health training, it's been eye-opening to understand what the issues are. So when we look at patients, we will label them as non-compliant, non-adherent to taking their meds or going to their appointments, but we don't generally ask why. Yeah. And usually it's some sort of barrier that they had. Maybe the referrals didn't go through. Maybe they couldn't afford their medication. Maybe they didn't know how to take their medication. Maybe they couldn't get transportation to go to the doctor. Maybe we told them they needed to eat healthy and lose weight, but they actually couldn't afford their food, or maybe they were losing their house. So, there's all these barriers in front of patients, and just alone, the navigation through the healthcare system is outrageous.
I was going to say that's a big part of it. Yeah. I can imagine people giving up at some point.
Exactly.
Even if they're aware that care exists for them, Sometimes it's too hard to get just because it's a pain in the ass.
Convolution does not do it justice to the absolute mess.
So, being able to understand what their barriers are. And I think as physicians too, we don't really understand what public health has to offer and all the available programs that are out there. Because I'll ask, physicians and they're like, oh, I had no idea that existed for patients. Like, where are these resources coming from? Well, it's like public health has them, but there's all these projects and all these initiatives and all these programs that are working, and we all work in silos. And so there's like no cross communication and data sharing. And so it makes it so difficult for, physicians to learn what's all out there for patients. They don't get the resources they need. And so they end up being labeled as non-compliant and non-adherent in their chart without a full understanding of what it is that they're going through at the social, economic, and, aspect of their environment.
So I'm going to use a military analogy, which I don't do a lot of, but I just don't have a better example. I have a friend who got her MPH several years ago, and we've had conversations about the antagonism between physicians and public health. And essentially, I think we kind of came to the conclusion, trying to talk it out, is that public health they're kind of like officers. Like their job is to see the whole battlefield. Their job is to kind of see the whole thing and think about the big strategy. And physicians or doctors, they're more like your NCOs, your sergeants, right? They're the ones that are in charge, but they're in the trenches. And you do need both of them, but it's also very easy with that analogy for me to see what the blind spots are and why there'd be contention between those two. Because as a doctor, often you're thinking, like, they don't know what it's actually like to be in front of the patient. They don't know what these problems that these patients are facing, right? Or whether that's from a non-compliance standpoint, because some patients just, it is really frustrating to care about a patient more than they seem to care about their own health. So that's one thing that doctors see, right? There's also the bureaucracy, the burnout that physicians have to deal with that is already making them exhausted. And then on top of that, there's I can tell patients to do that, but I know that they can't do that, right? And then at the same time, public health is, taking a step back and looking at this, and I'm like, look, you keep just kind of putting a Band-Aid on a bullet wound over here. Like you're not actually addressing the real problems. And both of them are just kind of exhausted looking at each other, scratching their head. I think that's one of the reasons why this is the specialty that calls to me so much. Is somebody's got to bridge that gap. Somebody's got to be able to communicate between the two worlds, because the patients deserve it. So.
Right. Exactly. Yes. I think in preventive medicine, public health, it's really good because you have a sense of both, how to manage the population, but you also have that experience of seeing patients one-on-one and understanding, the difficulties on both sides. And so I think that is quite helpful when you're trying to manage populations, just to have that baseline knowledge.
Yeah. So you've kind of already addressed this, but I want to bring attention to an important difficulty, I guess, in public health and preventive medicine, which is, where do you start, right? So I've done malnutrition work and with pregnancy and infants, and that's a great place to start for preventive medicine. Before they're even done gestating, let's make sure that we're preventing disease, right? But for the vast majority of our patients, like you kind of said when you were talking about your struggles in your intern year in family med, they've already got the chronic disease. So how do you, as a preventive medicine physician, you're thinking, my job is to make sure that I'm preventing as much disease as possible. How do you walk into a community that, unless you're dealing almost exclusively with maternity or newborns, your population probably is already managing chronic disease? Does that make sense?
Yeah. So I think there are different levels of prevention. So there's primary prevention, secondary prevention, tertiary prevention. So your primary prevention is for all the population, right? Those are, health promotion and vaccines. You just do it for everybody to prevent any sort of disease to come into play. So public health is very good about their health promotion efforts. And so, we have teams that go out in the community, they provide education. They partner with schools and different agencies to, educate the population and so forth to, make sure that people are leading healthy lives. So then we go to secondary prevention, which is, you've got a population at risk. And, they might need screening. So for example, people who smoke, they need lung cancer screening, and there's like criteria for that. And so you can educate them and you can, provide resources, like help quitting smoking and so forth and doing your lung cancer screening and whatnot. So there's health education there. And then you got your tertiary prevention, which is for people who already develop chronic disease. So obesity is one. Obesity is a chronic disease, but it also, I call it, is like the gateway to other chronic diseases, right? Because adipose tissue doesn't just sit there doing nothing, right? It creates havoc in the system. And so a lot of metabolic issues and hormonal issues, and then it can also increase your risk of developing
issues.
Yeah, MSK issues, cardiovascular disease, type 2 diabetes, all your bread and butter chronic diseases. And so they've already developed it. So how do we prevent it from becoming worse and having complications down the road? So you can do health education and things like that to be able to, prevent things from getting worse. But it just depends on what is your population that you're looking at. So your denominator is going to be different depending on what you're wanting to do and what type of prevention you're trying to accomplish.
Okay, that makes sense. So imagine, and Dave, you can go back and edit this if this is a dumb question. So I'm imagining, you have a patient coming in, 30 years old. Oh, thank you. 30 years old.
Don't edit that.
They're a little overweight. They're not like severely overweight, but they're already starting to see some comorbidities because of their weight issues. And you, as a lifestyle medicine, you're like, okay, how am I going to approach this patient? As opposed to family medicine, what would be the difference of the approach for a lifestyle medicine physician?
Yeah. So in lifestyle medicine, we get very good at doing what we call motivational interviewing. And I don't know if that's a term that you've heard before.
Yeah.
So we basically learn a lot of coaching skills to be able to drive people to change their behavior. And even people who are, ambivalent, like they don't want to do one way or another, or maybe they're contemplative, you try to drive them from one stage to the next. So you've got these stages, right? Pre-contemplation, where they're like in denial about their issue, contemplation, where they're like thinking about making some changes because of whatever issue they've got. And then they're in preparation stage, where they're about, 30 days out from making the change in an action, and then maintenance. And then they might relapse, so those are the stages. So in motivational interviewing, lifestyle medicine, you learn to move people from one stage to the next and to the next and to the next. And so, if they have overweight or they have obesity and they have some comorbidities associated with it, maybe they developed obstructive sleep apnea because of their weight, on their neck, or they developed hypertension, or maybe their A1C is now in the pre-diabetic range, which is showing me that they're insulin resistant. Then we start talking about their motivation for change. Maybe they don't care about the labs, to be honest. That's not their issue. The issue is they can't go up the stairs without getting winded. They can't keep up with their grandkids, and they can't go on airplane rides because it's just too much. And, maybe their size is too large. It makes it difficult for traveling. Maybe they can't go to the amusement park because it's just, it's just not physically feasible for them. And they would like to do those things. So we basically ask patients, like, why is it that you want to make the change? Because everybody wants to lose weight, but what is the reason behind it? And what is it that's really important to you for you to making that change and making it sustainable? So we really try to get to like the very root reason as to why they need to make the change, and use that to help them, go along and move along those stages. So we would start with, assessing nutrition and their physical activity and their sleep and their stress. And, are they using any toxic substances? Are they smoking? Are they, drinking a lot of alcohol or using any street drugs and whatnot? And then looking at, what kind of support do they have around them? So that's the way that we frame it. And then the way that we do goal setting with them is that we'll say, okay, instead of saying you need to eat healthier, that is way too vague. And I see that in charts all the time. And I'm like, that's a good effort. You get A+ for effort, but we need to work on being a little bit more specific. So that's when we talk about having SMART goals, where they're small, measurable, attainable, realistic and timely. So you have to make them very specific. So basically you're saying, okay, well, I need you to eat healthy. Maybe they're only eating 1 serving of fruit and vegetable every day. So they're definitely not getting enough fiber and not getting a lot of the phytonutrients they need. So can you make it 2 servings? I need it. And how often can you do that per week? And, is it going to be what?
Inch by inch. Yeah. Exactly.
Yeah, inch by inch. Exactly. Because if they feel like you're asking them to overhaul their life overnight, they're not going to do it most of the time, unless they just had a heart attack. And this is for some folks, they'll have like a come to Jesus moment in the hospital where they just had a heart attack and they're like, I have got to do something because I am not ready to die.
Yeah.
And they will change, they will overhaul. So Loma Linda is interesting because they have the one in, to my knowledge, the only inpatient lifestyle medicine consult service in the country. And I was able to rotate through that briefly and learn how to do lifestyle medicine consults and whatnot on the hospital setting for patients exactly like that. And so those are very teachable moments for patients, but you have to make it, for most people, they can only tolerate small, little, tiny goals. And so, maybe it's exercising 10 minutes per day to start out with, until they can get to the 150 minutes of physical activity they need to have per week at moderate level, with 2 days of strength training. So you just have to start very small with them and then just consistently check up on them, then slowly increase and challenge them, but make it so it's, attainable for them over time.
I would say for people that are maybe uncomfortable with the terminology, like people can't handle big goals or whatever. Like, this isn't necessarily, we're not trying to infantilize people. It's just recognizing that all of us have a full life already. Our minds our plates are full from the moment we wake up until the moment we go to bed. And small additions or small subtractions here and there, those are feasible. But, you start moving too much around and it's just too much to think about. You don't have the brain space for it.
Exactly. Yeah. And obviously this is case by case, right?
Yeah.
But generally speaking, you try to make it small. Some people are ready to go all out. And there are times when I'll see patients and they far exceeded their goals. But that's because they were motivated and they're ready. And I'm like, okay, let's do it, and you get on the same page. But the goal is to make sure that you're meeting them halfway. So even if you're in clinic or, with family medicine or, internal medicine, you're doing primary care, try to meet them where they're at. And make one small little goal for them that's very specific that they can do, so they feel like that they're successful and be able to take on bigger challenges over time as they get used to their new routine.
Well, you made it to the second break. You tolerate us. If you can, consider donating or buying a sticker or something. Visit theshortcoat.com and help us do stuff without having to beg a dean for money. Thanks.
Dr. Caswell, how does a patient access you? I was in fitness and wellness for a decade before stumbling on here. I was a group fitness instructor too, and
he's got the 6 packs to prove it.
Oh no, yeah, only things that end in cerveza. But no,
it's one of the medical school side effects, or medical training side effects.
Yeah, but exactly like what you were saying. My question is the fact of, because individuals who can afford group fitness, individuals who can afford a personal trainer or a health coach or anything like that, I feel like there's the majority swath of the population who can't afford those more expensive avenues. How do people access Prev-med? How do people say, I know I need to make a change, I can't afford to go the private route? How is that publicly accessible? Do they get a referral? Do they walk into a clinic? Because you said you're one of, if not the only one of 2 in Loma Linda inpatient services. So what does that look like for everybody else?
Yeah, so here at Loma Linda, they have the lifestyle medicine consult service on the inpatient side, but I don't work there. I don't do hospital work. I just decided a long time ago I wasn't made for hospital. So, but here at Loma Linda, we have a Center for Health Promotion where they can go in and see a physician that is very much Prev-med geared and oriented. We do have an FQHC here. We have a lot of FQHCs in our county.
What's that?
Sorry, it's a federally qualified health center. So basically they receive federal dollars to be able to treat, care for the underserved.
Okay.
So the one associated here with Loma Linda, they have 2 lifestyle medicine clinics. One it's for run by Family Medicine. The other one is grant funded by HRSA, specific for women. So it's a women's lifestyle medicine clinic, and that's where I did about 6 months of my training doing obesity medicine, lifestyle medicine. Now I'm trying to start that from the public health side through the public health department as well for the other FQHCs, but that's a work in progress. And so there are lifestyle medicine physicians out there. There are preventive medicine physicians out there, and just a matter of being able to figure out where they are. And unfortunately, they're not everywhere because we're still a very small specialty, but we do exist. And sometimes we fall under different titles. Like medical directors can be one. So we're not always easy to find just because we carry different titles.
So you're making me feel like, we've talked a lot about on this podcast and medicine generally that, a lot of countries, they'll have a 70% primary care and 30% specialties, whereas in the US, we're more like 30% primary care, 70% specialty. And I think, don't let the bone guys come at me for this, but I think we could probably stand to have fewer doctors that are subspecialized in the tibia or whatever, hyper specialized in these tiny little areas. And we need more primary cares, but you're making me feel like I'm going to lump into that, your family medicine, your internal medicine, your pediatrics. I'm going to go ahead and lump in preventive medicine and those specialties that the country would be a lot better off health-wise if we could just get more people into these specialties. So what are we doing to do that? Or what are the barriers to people getting into preventive medicine, I suppose?
Yeah, so I think visibility or lack of visibility is one which we're, as American College of Preventive Medicine, is actively working on, and they have a visibility committee to be able to, augment, our position out there. We are here, we exist. We hide all these under different titles, but we do exist, and we have for a long time. So they are augmenting, that aspect, and we do want medical students to know about ACPM and to come to our conference. We have conferences every year in April. And so this one coming up is in Washington, D.C. in April 18th through the Saturday session with Dean Ornish, who's huge in preventive and lifestyle medicine, will be doing one of the talks. And, med students can join for a very small fee, to have a membership through ACPM. And that way, so they can network and figure out, where do I want to work, as an attending and on after prev-med. So they are increasing visibility there. I think that just the fact that we're trying to have all these other specialties know that we exist is also another issue. So we're working on, making sure that other specialties can, refer to us and, use us, especially in clinical preventive medicine. If you are not sure how to talk to your patients about, healthy living and, vaccines and, getting their screenings done, refer to us. We can do all that talking for you. So in a way, we're trying to increase our visibility. We're trying to, get connected with folks. I often talk about it on social media, which is a lot of the time how I find folks that are wanting to come into PrevMed. They're like, what? I want to leave my specialty. I didn't know you existed. I've always been preventive medicine minded, but didn't know there was a place for that in medicine.
I didn't even know that was a thing until yesterday.
Yeah.
You're welcome.
Yeah.
So it's an incidental finding. A lot of the time, most of the time it is. So for the med students that are finding out about it now through your podcast, they're going to be ahead of the curve, because as a medical student, you should have all the options available that are out there.
Yeah.
In front of you before you can make an informed decision about the specialty that you're trying to match into, I feel like. And I feel like we just don't know as med students. We don't know what there is out there. And I think that's
and a plug for Carver is every medical school is going to get you there, right? But one of the things I like about our school is because our clinical rotations start earlier, we have a little bit more time to look for those advanced rotations before we're applying. I have a couple of friends that they're like applying and they're like, well, these are the specialties that I recognize on my required core list. And like, that's the only ones that they've seen. Yeah. So that, and that's, hats off to Dave for making time to do these sleeper specialty podcast episodes so we can talk about these, because I started a preventive medicine interest group here at Carver specifically because like, I want to see more people going into this. I want there to be more preventive medicine physicians out in the world. So
I think this is a common problem. I will say, I'm happy that you gave me some credit for this, but I will say that I think everybody has this problem when they're looking for a purpose in life or a career. There's so many options out there that it's impossible to cover, all of them. In the 20 years I've been working here, I've come to realize how broad healthcare is. It's not just doctors. It's not just physician assistants. It's not just nurses. It's a whole ecosystem. It's a whole thing. And I didn't know that when I was a young person. I didn't know shit when I was a young person. But anyway, point is that
has that changed much?
I feel like the older I get, the less I know, actually, the less certain I am of anything.
That's probably pretty healthy though.
This is absolutely.
Dave's probably forgot more than I'll ever learn. So
okay, but I forget a lot more than other people. Yeah. So
you gotta.
I think it's the point I'm trying to make is it's not an uncommon thing, and yeah, I wish there was more. I wish there were more to sort of bring these opportunities to light.
Yeah, I feel like Prev-med just has a marketing problem, but everything else is absolutely phenomenal.
Yeah.
I have to ask the question because, of course, I'll get railroaded by all my colleagues if I don't. What does it look like for PAs in Prev-med? Are there PAs in Prev-med, or is that one of the avenues where like, oh, we never even thought about that?
Yeah, I've never had a question from a PA in Prev-med, but I know that I've had questions from other healthcare professionals, like nurse practitioners that have wanted to join Prev-med. Right now it's for physicians, like the ACPM is for physicians, but I don't see why in the future, you can't open that up. But, I'm not an admin for ACPM, and so I can't say that for sure. But ACLM, on the other hand, which is the American College of Lifestyle Medicine, they are open to all healthcare professionals, and they have interest groups for, all the different types of healthcare professionals. And so those are open, but that's specific to lifestyle medicine.
Yeah.
I'm just seeing in the future, I'm going to have a clinic, like a preventive medicine clinic, and Connor's just going to be my PA running the show.
It's one of those things that seems so on the nose, like you said earlier, Dr. Caswell, where it's like, oh, isn't every physician and PA and NP and nurse supposed to be doing preventive medicine? And then you're like, nope, it's actually, well, of course, but it's actually a specialty in and of itself. And then it's like okay, so why aren't we doing a million new providers a year on this? It seems very Thanksgiving table.
Yeah. So the issue has been historically the way that we run healthcare system in the United States is a very reactive system, right? The way that you're saying how there's like so many more specialists than primary care, but that's because we trained ourselves to be reactive. And then we have an insurance coverage system that is very much reactive and doesn't really pay much for prevention. But now they're starting to realize, oh no, we can't deal with the chronic disease burden that's coming. Yeah. And so we need to do something about it. And so there has been a lot of talk in terms of doing value-based care where, you're paid for, outcomes. And so you're not being paid by, volume anymore. Although, some specialties, they'll continue to do that, because they got to get a number of procedures done and whatever, like if you're a surgeon. Yeah, and your RVUs. But generally speaking, like you get paid as a package, basically, per patient. And so they're expected to do well. And so now that we're going towards that, then I feel like prevention is getting a lot more attention. And I think there's a lot of room there for expansion in preventive medicine, because they're going to understand, oh, we're going to need this because, like we can't deal with the chronic disease burden. It's just too expensive for our country to deal with all the chronic disease. And we have to do something about it.
What would you say?
There are large established clinics that have done wonderfully with the value-based care model. So anybody that's interested in this, don't feel like you have to be a trailblazer. You certainly will have the opportunity, but like there are models that we can build on, we can replicate, we can scale. And I think that's wonderful. Yeah, also, just my plug, I am going to be in DC for this conference in April. So if somebody needs a roommate at the hotel, just email Dave. He'll get you.
There's definitely models out there that are coming, like Medicare. They do chronic care management, where basically you have a team in the clinic that, deals with your higher complex patients. So it's a team of, a case manager, a nurse, maybe you have a health coach of some sort, and the physician, who are all kind of like working together, make sure these higher complexity patients have some attention. There's also enhanced care management, that is being implemented, for patients on Medicaid. And that's something California is trying to do. So, and it's the same concept, it's like a team-based approach for these patients that need additional care because they are higher complexity. So, they're looking for more ways to, stop that derail train from just, having more issues.
Yeah. Yeah. I have one last question.
Sure.
Before I let you all go, because we're getting up there. We could go on for this. Is a really great topic, and it's really interesting to me personally.
I could talk about this for hours.
But my question is, it's getting back to the subject of attracting people to the profession. One of the things that I know that students think about is the lifestyle of the specialty that they're getting into. So ignoring intern year, which is, this.
You put that off to the side.
I mean, it's kind of an outlier.
Nobody likes intern year.
Yeah. How did you find the rest of your training, and then what would you say for most physicians who might end up getting into preventive medicine? What does that look like?
Yeah, that's a great question. I love that you asked that, because I meant to say that earlier and failed to do it. So prev-med training, unless you're doing an elective in the hospital, which very rarely do people choose to do that, it's no weekends, no holidays, no nights, no on-call, nothing. Like you're Monday through Friday. And then you might be studying, whether or not you're in an MPH program.
I'm sold already. Honestly.
I was going to say, it sounds like a perfect crime. Yeah.
Yeah. It's crazy. There's I remember being in residency, and there's over 50 specialties through the Loma Linda system. And there's 52 or 57, something like that. And we were one of the only, I think we were the only ones that didn't require pagers. And
love that.
And so and
get to live in the 21st century and everything.
Yeah, it's pretty amazing. So you have a chance to be a human through residency training. Of course you're busy, you're still doing a lot of hard work because you are still learning, but it is more human. And then now, even same way, I work Monday through Friday. I don't work holidays, but I'm a government employee. So, I get all my federal holidays off.
I'm certainly not going to bash a government employee.
And so we do have good time off that way, and it feels more balanced. I'm a single mom. I have 3 kids. And so I am busy with my kids, but I can, do my, I can do telemedicine on the side. My oldest right now is in high school, and he has a horrific soccer schedule through the high school. And this week it's literally every day there's something going on, but I can manage that, and with no help. And so it feels very manageable. Is it busy? Yes. Is it a lot of hard work? Yes. But I'm not in the hospital at night at 11 o'clock at night trying to answer pagers, I don't have any of that. So it is really nice.
Sounds nice. Yeah. Well, we have to wind this up. That's our show.
Dr. Caswell, it's been lovely.
Yes. Thank you for joining us today.
I've totally enjoyed this conversation. It's been so fun, and I appreciate being invited on, and I'm super appreciative. So thank you.
Go check out the American College of Preventive Medicine, right?
Preventive Medicine, yeah.
And just find out more about the profession. And Jeff, thanks for producing today's show and asking Dr. Caswell to join us.
Yeah, it was an honor.
And Conner, thanks for being a part of it.
It's been lovely. Thanks for putting out my questions.
Come to more shows.
You're gonna be stuck with me. I'm gonna become rattling questions.
That's fantastic. What kind of silly man would I be if I didn't thank you, Shortcoats, for making this part of your week? If you're new here and you like what you heard today, follow the show wherever fine podcasts are available. You know where they are: Spotify, Apple Podcasts, Google Podcasts, YouTube. The show is made possible by a generous donation by Carver College of Medicine student government and ongoing support from the Writing and Humanities program. Our music is by Dr. Vox and Catmosphere. I'm Dave Etler saying don't let the bastards get you down. Talk to you in 1 week.
Gosh, that sounded good.
Yeah.
That was
have you narrate my life.
Hi, Shortcoats. Look, life in medical education, life in America, life in the world is often difficult. And I often wish I could help. All I have is this podcast, but in my wildest dreams, you have the support you need to lead a life of your choosing. You deserve to be happy, healthy, and successful in whatever ways you define those words. So if you need support because you've experienced racism, discrimination, harassment, mental health crises, I want you to be able to get the help that you need. And so I'm going to put some links in the show notes to some resources that you can use. But the bottom line is that for what it's worth, I see you. I know you're out there. I wish I could do more. Maybe I can in ways that I don't understand yet or know about. But I see you, and I'm glad you're here, and other people are too. This Short Code podcast is a proud member of the MedEd Media Network. Inspiration, information, and guidance on your journey to medical school and beyond at mededmedia.com.